All right, moving forward, so we're going to talk about typical pharmacologic management for these headache disorders, migraine specifically. So again, remember that we can't do anything for the auras that patients may experience, but that could be a good trigger to think, hey, I should probably take these medications here to maybe prevent the migraine symptoms from coming on in that point there. We like to limit it to no more than 2 days per week because you tend to develop what they call like a medication overuse headache. You can see with kind of more frequent use of these medications. So if they're taken like every single day, that can be problematic, as you'll see. Typically for acute management for say more mild to moderate symptoms, this is where your typical like over-the-counter NSAIDs and maybe Tylenol can also be useful here as well. Typically though, you're going to require, Tylenol is not really going to be enough to do it on its own. But certainly including things like, ibuprofen, naproxen, things like that can be pretty reasonable. You'll see a lot of like over-the-counter like headache or migraine formulations, especially like related to like, menstrual-related headaches actually include caffeine. Why do you think they include caffeine? Vasoconstrictive, right? So it's going to help to release some of that pressure there. We mentioned that vasodilation causing pressure in the CNS is what's causing a lot of that initial sort of wave of depression leading to that pain there. Generally, we don't use opioids for these patients for the most part unless they are just totally refractory to all other therapy there. We don't usually do that. If I have patients who are coming in to like say like an urgent care or ER setting and I can use something parenterally, that's where I want to consider using something like Toradol. Like ketorolac is a really good drug for that setting there. So it's pretty common that they would get that. Keep in mind that ask them what they've received already. So they may have taken like a big dose of ibuprofen, say 2 hours before they came in. I'd probably want to wait a little bit longer before I hit them with a dose of Toradol, right? Maybe we'll wait, say 3 or 4 more hours before that would, that way don't cause something like GI upset and things like that. You also have to manage the nausea and vomiting. So certainly we've covered drugs like that will work for that as well. So something like Zofran would be perfectly reasonable for that. Sometimes patients they don't mind taking a nap after one of their big migraines, so you can use something more sedating depending on the situation there. So something like a promethazine or metoclopramide would be totally reasonable for those patients there. I see a lot of patients in at least in the ER where I see these orders at prochlorperazine or compazine is a pretty common one I'll see. So they may, for instance, do something like Toradol plus compazine to initially treat the migraine and see how they respond to that. Usually get some fluids as well because people tend to feel better after a liter of fluids. The other big thing you'll see here as well is that a lot of the abortive medications we're going to use for the migraine itself actually cause nausea and vomiting, so it's good to pre-treat for that. They'll probably be nauseous anyway, and the drugs can exacerbate that. So that's why we're going to go ahead and give them that. So for moderate to severe migraines, this is where we're going to bust out our ergots, right? And we've kind of talked about ergots before when we talked about some of the dopamine agonists back in Parkinson's. This is going to be sort of similar to that. But instead of working on dopamine receptors, we're going to be more focusing on its effects on serotonin receptors. That's going to be kind of the big difference here. So 5-HT1D and 1B are going to be the major receptors we're going to focus on for migraine treatment. So the ergots themselves, mainly we're going to see things like ergotamine tartrate and then dihydroergotamine. I see that one more commonly. It's called DHE. That's how it's commonly abbreviated to. And so again, we have different dosage forms depending on the patient's nauseous and they can't take anything orally, so there may be like suppositories or nasal sprays, or we may just give it parenterally, say IV or IM. So this is going to be working as a vasoconstrictor, so as you might imagine, who might this not be a great option for? If they're really hypertensive to begin with, right? So if they maybe have a history of stroke or a history of MI or if angina, things like that may preclude you from using one of these drugs because they do cause pretty significant vasoconstriction. We talked about St. Anthony's fire. Remember we talked about that? Remember the vasoconstriction? They feel like their hands and toes are on fire because of that vasoconstriction that was decreasing oxygen delivery there. But basically by causing that vasoconstriction, and then also there's some presynaptic activity that actually helps to decrease pain and inflammation as well. That can also be an additional sort of side benefit there. So the nice thing with the ergots is they have a pretty long half-life, so this helps to prevent recurrence of symptoms. Some of the other ones we're going to look at, like the triptans, they tend to have a little bit shorter half-life, so they may feel better in the ER, but you send them home, and a couple hours later the migraine comes back, which is not ideal. This gets around that by having a little bit longer longer half-life. Side effect profile tends to be a little bit harsher with the ergots, which is why they kind of go a little bit more second line in a lot of patients, as I see, but this is the older one, so it's been around for a long time. Typically, you'll see a lot of nausea, vomiting associated with it. They may get a lot of chest tightness and their blood pressure may rise. So you want to definitely be monitoring for that. As I mentioned, that ergotism due to that peripheral ischemia. This is not common, but say for instance patients got too much, or maybe they were taking, they had an intranasal dose at home that they had taken, and they come in and they neglect to tell you that, and then you give them another dose. This is where stuff like that can happen. So in rare cases, you could even see things like gangrenous extremities like we talked about before, that St. Anthony's fire. In terms of contraindications, though, definitely if they have that history of vascular coronary disease, if they have, uncontrolled hypertension, if their blood pressure is like 180 over 100, this might not be a good drug I'd want to start with for them. This is also very teratogenic, so this is going to be a category X drug. You would not want to use this in pregnancy. As you might imagine, constricting all those little vessels in the fetus sound like a good idea? Probably not, right? So this is not going to be a good option for pregnant patients. And then we also don't want to use these within 24 hours of the triptans. That's the next class we'll talk about. Those are going to be more the kind of the gold standard drugs you're going to use for most patients with migraines. The other big thing that you'll find is that some patients with migraines, they kind of know what works for them. They've been through the ringer several times, and they'll say, yeah, sumatriptan doesn't really work for me. DHE works great. You should be able to take that with a, say, okay, well, let's go ahead and go with that. Make sure they don't have any contraindications. Make sure they're not pregnant, and maybe a really good option for them in some cases. But don't use them within 24 hours of the triptans, because you will find they can work synergistically with one another, and that can even worsen the hypertension more so. So next, we have the triptans, and again, these are going to be probably far and away the most common ones you're going to use in your practice if you manage patients with migraines at all, which does come up pretty commonly. You can tell it's a triptan by looking at the end of the name. Those have triptan right there. These are working very similar to the ergots, so they'll have 5-HT1D and 1B receptor activation. Keep in mind, though, they don't have any dopamine activity like an ergot might. Okay, so that's kind of the big differences between those. Again, sumatriptan has a lot of different dosage forms, so they can have like a nasal spray you can use. You can get this subcutaneously, orally. Just depends on what is going to be tolerable by the patient and what you're going to be writing a script for them. They may have it on for outpatient use potentially. The big differences between these are all going to be little things like, what's the half-life of the drug, right? What's the rate of recurrence with them? What does the patient's insurance cover? Most of the time, sumatriptan is probably going to be the cheapest and easiest one to go with. It's the oldest of the bunch and is definitely generic, so it's probably going to be, probably more unlikely what most patients are getting started on. And if they don't do well with that, then you can try a different triptan in the group there. So, as I mentioned, they're going to be vasoconstrictive. Yes, sir. We will look at that in just a moment, sir. Yes, good segue, but we'll get to Frova in just a few moments. So anyway, so as I mentioned, this tends to be pretty effective for these patients here through its vasoconstrictive actions on the serotonin receptors, but just be aware that, especially with the shorter acting ones, something like a sumatriptan, about 40% can have recurrence within the same day. So you want to make sure your patients are aware of that. Say, hey, this may come back, there's a chance that you don't want them to be caught unawares, otherwise they may think you're not really taking good care of them. This is going to be decreased though if you use things like Frova or Emerge, where they have much longer half-lives. So side effects are pretty common with these, and these make sense based off the mechanism to go kind of along with what you see with the ergots. So you can see, especially with like big IV doses, you can see things like chest tightness and pressure and pain. This is typically transient. It should go away after the drug is kind of in the system for a little while, 20-30 minutes or so. But they can get some paresthesias and dizziness and things like that. This is why some patients may not want to take it again, because if they feel that way, then they just probably don't want to take the drug from that standpoint. Obviously, contraindications will be similar to the ergots, things like coronary artery disease, angina, MI, anything where you're worried about decreased blood flow to certain critical organs, you'd want to be cautious here. And we'll talk about MAO inhibitors when we get to the behavioral health section next. And again, don't use this within 24 hours of ergots. Now, this one is not contraindicated with pregnancy. Ideally, if you have a pregnant patient, how much drug exposure would you like them to have? 0 would be ideal. I'd like all patients to never need drugs, but unfortunately, that's not the world we live in. There is some evidence for use of things like triptans in pregnant patients, because that question comes up pretty frequently, but it probably would not be the first thing I'd jump to. I'd probably want to try some other things like, maybe they're in first or second trimester, an NSAID, try some Tylenol, but, most of those are not going to really cut it for true blue, or really true migraines. Did you get a question?
No, it was about pregnancy.
Okay, there you see. I know I get the question often, so I like to head it off before they ask it.
Would you advise for someone who's pregnant to take an NSAID and just caffeine?
Depends. I mean, what's their blood pressure like? Do they have preeclampsia? Caffeine's not necessarily going to be. I don't know that taking like an NSAID and caffeine is going to be the thing to do it for a lot of migraines, but And again, you have to be cautious. Third trimester, you don't want to use NSAIDs for them because it can be some issues with fetal blood flow and things like that. So there's not really a good option. Like sometimes, and most of the times, a lot of pregnant women, do they want to take medications? Like, no, just suffer through it. Like the mommy guilt is kind of a big driving factor for a lot of people, I know. And so at least it was for my wife when she was pregnant. She was like, I don't want to touch anything that might affect the baby, because you never know. Like, what if that one drug exposure caused this thing that happened to them when they were 35? They got into a car wreck and it was because I took some sumatriptan. I don't know, just weird stuff. Like you jump to weird conclusions. Like so, in those cases, there, most pregnant women probably want to avoid drug exposure if possible. But anyway. So the first generation ones, mainly sumatriptan, kind of falls into that category. The second gens tend to decrease headache recurrence. They may have a little bit better bioavailability, which is why frequently sumatriptan is either given as a nasal spray or like a sub-Q injection, because it's pretty poor bioavailability there. And you'll find with the second gen ones, you typically will have a little bit fewer adverse effects. The one caveat, the ones with longer half-lives that reduce that recurrence, they typically have a slower onset of action. So you may not get the same sort of like immediate relief or very quick relief you might see with like a shorter acting one like a sumatriptan or something. Also, other things, they'll have like better penetration to the CNS. That also increases, the activity of the drug itself, better receptor potency. So overall, we tend to think these work a little bit better, but they may be more expensive depending on if they're brand only and what the patient's insurance will cover, etc. So just to give you some examples, and you don't need to know the dosage forms for all of these specifically. I just kind of illustrate that to say like, oh yeah, well, these patients are super nauseous, like they may not be able to take anything orally. We have other options that are available for them. So for instance, with like zomatriptan, there's an ODT. Anyone remember what that stands for? It's an oral disintegrating tablet, right? We talked about those back with Zofran. So again, patients are nauseous, they don't want to swallow anything. You just put that into the mouth, it'll dissolve and can absorb buccally from the mucosa there. Naratriptan's another one, has a little bit longer half-life, will have reduced recurrence there, which is nice. Maybe have a little bit more favorable profile than something like a sumatriptan potentially, but a little bit more slow onset, 4 hours or so, which can be a long time if you're experiencing a migraine, depending on the situation, right? Rizatriptan is another one here. This one's interesting because we'll talk about prophylactic drugs to prevent migraines, and one of those is actually going to be propranolol, another beta blockers. Actually, when you mix this with propranolol, you actually end up seeing a decrease in the metabolism of the drug, such that the AUC, or the area under the curve, basically a measure of how much drug exposure you see there, goes up pretty significantly, which means that we actually have to reduce our dose of rizatriptan if you were to mix this with propranolol. So that's a kind of an important interaction to consider. It's kind of a unique one amongst this class here. So for instance, if you're taking it by itself, maybe you do 30 milligrams a day, versus if you were to say take it with propranolol to prevent migraines, then you may only do say 15, right? So it's another important interaction to note there. So amitriptan is another one that has really good bioavailability, but this one may have more drug interactions due to things like CYP3A4 interactions. It's metabolized through that. Monoamine oxidase is also another important enzyme we'll talk about in behavioral health, but you already know about this from Parkinson's, right? What does monoamine oxidase do? Metabolize like dopamine, but it'll metabolize other things like serotonin and things like norepinephrine. So you will see some interactions there potentially, especially if they're on other serotonergic medications like our antidepressants we'll talk about in a little bit. Elatriptan, another one metabolized through CYP3A4, so it could be potentially rife with drug interactions. And then frovatriptan, this one's nice because that's just a really long half-life, 24 hours or 25 hours. So recurrence rate are going to be much lower, but again, slower onset of action most likely. So looking at this, in terms of acute treatment for these migraines, typically which route of administration do you think would be fastest? Probably supplement would be okay, but what would be faster than that? IV would be the fastest, right? Or like a sub-Q dose would be a little bit slower than that. Buccally, or through like an oral disintegrated tablet, can have pretty rapid onset. It does bypass the liver, which is nice. Get some first pass effect that's kind of mitigated there. Orally, obviously, is going to be the slowest route, right? But patients may not want to inject themselves at home. Nasal sprays tend to be pretty easy to administer for patients at home. Just depends on what they're going to be comfortable with doing. As I mentioned, do not use ergots and triptans within the same 24-hour period or so, because you could see really excessive prolonged vasospasm there, leading to things like MI and stroke and whatnot. And then we like to avoid using more than 2 days per week if possible, mainly because of the fact that you can see kind of this overuse headache where they end up developing worsened headaches, and it's actually related to using the medication too frequently. It's kind of this paradoxical sort of thing you see there. So just kind of a nice flow sheet, kind of walking you through how you would manage one of these patients. Let's say we make a diagnosis of migraine. We kind of assess the severity of associated disability. We'll talk about prophylactic medication in a moment, where we talk about things that are, for patients that have recurrent migraines throughout the month, or they're really disabling. We can definitely talk about prophylactic drugs here. For more mild to moderate symptoms, start off with the easy stuff. Try some Tylenol, try some NSAIDs. You can use the two together potentially, see how they respond to that. If that's not working, maybe add in some caffeine, see how they're responding at that point. Most people tend to be pretty, resistant to the effects of caffeine, because most of us are so laden with coffee all the time anyway that it doesn't really make much of a difference. And then at that point, that's where you want to consider adding on a triptan. For more severe symptoms, though, if they're having really severe headaches, say they're showing up at the ER, the urgent care, this is where you bust out the big guns right away, right? So you can either use a triptan or an ergot. Most places will probably go triptans first 9 times out of 10, unless they know that it doesn't really work that well for them. Then you can go something like a DHE. I'd probably use that secondary. But remember, you probably want to get something like a pregnancy test if it's a female of childbearing potential, right? If those are not working, then we can talk about maybe some combinations. Maybe things like, using a Toradol plus a triptan may be a good option, right? And a lot of times patients, when they come in with these headaches, they'll frequently get, get Benadryl, they may get Compazine, and then they may get Toradol together at first to see how they respond to that, maybe some IV fluids. And if they're still not responding, that's when they'll bust out the abortive therapy like a triptan. So that's something you may see with some regularity there. Opioids, again, typically we don't like to go with that if at all possible. Yes, ma'am.
Do you have to wait a certain amount of time before giving a triptan if they've already taken Tylenol and an NSAID?
In those cases, no, because they're working through different mechanisms. I don't really care, right? So again, if I give them, say Toradol, they had some acetaminophen at home, I can give them a triptan immediately, right? The only issue would be if they receive like an NSAID at home, like they say, I already took 800 of ibuprofen at home, and then you consider giving Toradol. You have to think about the time frame. You want to, at least 4 to 6 hours, I would say, to separate that out. Yes, ma'am.
The rizatriptan,
Mm-hmm.
it says there's a daily max. Is that something that you take daily for prophylaxis, or is it just when you're having an attack?
When you're having an attack, that's how much you would be able to take in a day.
Okay.
Yes. Yeah, I definitely do not want to take these prophylactically every day. Yeah, I'm just saying what the max would be.
And then the ergots, is that something that's mainly done just in the acute setting of the ER, or is that something they can walk out with a script?
They can walk out with a script for it. I don't know how frequently pharmacies carry it nowadays, but it is something they could have a script for potentially. Mm-hmm. Maybe like a special order kind of thing, but yeah, they could potentially see that. Okay, looking at medication overuse headaches. So again, as I mentioned, this is where patients are kind of chronically sort of self-treating themselves. Maybe they're taking triptans, maybe they're taking opioids, maybe they're taking all kinds of other things. Typically, we're considering if they're, say, more than like 15 days per month, this may be related to medication overuse headaches. They're kind of getting worse in headaches or treating with more drugs, which makes the headaches worse. Not great. So ideally, what would you do in these cases here? Stop giving them medications, right? But then they're like, but the headaches will come back. Patients may be kind of hesitant to do that. So titrating them down is going to be a really important thing to consider there. So see how severe their headaches are, how frequent they are. If you can, try to titrate down on the dose and how often they're using it. That can be effective. Typically, depending on how much they're getting, you may not want to stop them cold turkey, especially if it's more than, say, like 12 caps or tabs a day, or if like they're pregnant, you probably don't want to abruptly discontinue because they can cause pretty bad rebound headaches. But certainly this is where you can consider starting with some prophylactic medications, which I'll mention in just a little bit. Again, if you're withdrawing the medications and they start to have rebound symptoms, again, you can kind of go back up on the dose and then restart the wean at that point. So who's a candidate for preventative therapy? Typically, if they either have a lot of adverse drug reactions to the abortive therapy, maybe they're not good candidates for things like ergots or triptans. If they are having recurrent symptoms during the month, yeah, absolutely consider doing preventative therapy for these patients here. Beta blockers tend to be most effective in the majority of patients here. We like propranolol. If you recall, is propranolol typically very lipophilic or hydrophilic? This one causes like a lot of nightmares in elderly patients. Really lipophilic, right? It can cause seizures in some cases, but yeah, it's very lipophilic. So that's what we like because it typically is going to be pretty good to get into the CNS. Any of the beta blockers will do though, right? So you could use a atenolol, metoprolol if they have like a history of asthma, anything like that's totally fine there. Again, you may think that, well, wait a second, wouldn't a beta blocker, what would that do to the blood vessels? Would it constrict them or dilate them? You'd think they would dilate them, if anything, right? These are antihypertensive medications. So initially, if you were to say start off with a full blast dose of propranolol, guess what you can induce? a migraine in the patient, right? Not ideal. So this is another one where basically by starting low and titrating up, you can sort of kind of regulate that vasospasm and sort of prevent that vasodilation that would normally cause a migraine from occurring in the first place. That's kind of the idea of why they would do that.
Can you still get the rebound effect with propranolol, or is it like less of a dose than in the cardiac section of the upper extremity?
Say it again?
You said in the cardiac section
Mhm.
with propranolol, like if you take them off it or if they stop taking it, they can get like the rebound.
Oh, right.
Is this like a less dose?
I'd have to look at the dosing specifically to see if there's, again, you're titrating to effect in a lot of cases there, so that you may find similar dosing between, like, a tachyarrhythmia or hypertension versus migraine prophylaxis. I would still consider, if they're on it long term, to titrate them off, because again, you could see rebound migraines when they're coming off of it too, so that'd be something I'd probably want to avoid for sure. You can also use some anticonvulsants. We have talked about these already, right? My classes start to blend together after a while. I'm like, wait a second, what year is it again? Is it 2018, 19? Yeah, so we've talked about some of these medications. So things like our anticonvulsants, things like our divalproics, valproic acid can be used here. Again, they're thought to sort of like help to block some of that spreading wave of depolarization that causes the migraines. Topiramate another one you probably see pretty commonly, mainly due to lack of side effects and some relative efficacy there. Again, just be aware of, you know, things you can see. So like with valproic acid, like what's a common side effect? Is that common? No, but it is something you should know, right? It's a rare thing, right? There's killers, there's commons, and there's zebras, right? You guys heard that when you're thinking about your differential diagnoses, right? The killers are the really bad stuff you have to worry about, right? That could kill your patient. Commons are things you would expect to see routinely, and the zebras are like the one-off kind of deals. So if you had a patient with pancreatitis and you were able to get back to valproic acid, that's kind of a zebra, but it's still good you know that because you look like a rock star if you diagnose it, right? But this is one of those cases there. So commonly, if you're causing the neurons to not fire as often, try to chill them out, what do you expect the side effect to be? Sedation, right? Ataxia, dizziness, things like that. You expect to see that. Topiramate, again, beware of some of the paresthesias that can happen due to its effect on causing some acidification of the blood, right? So you can definitely see that in those patients. You can't use things like tricyclics and SSRIs occasionally. We'll talk more about this in the behavioral section coming up. Basically, we'll talk about their mechanism as basically inhibiting reuptake of certain neurotransmitters, SSRIs being specific for serotonin versus tricyclics going to be for serotonin and norepinephrine, but we'll get into much more detail on those in just a little bit. Other things you could do include like your calcium channel blocker, so things like verapamil could be used. Maybe if they're not a good candidate for a beta blocker, you could try using something like verapamil or diltiazem is a possibility. People have also tried some of the dihydropyridines as well, things like nifedipine potentially. Just depends on what they're going to really respond to, what they're going to be tolerant of. I see a lot of patients will start out on something like topiramate, especially if they're not a good candidate for a beta blocker or a calcium channel blocker, right? Probably like beta blockers being kind of second after that, I would imagine. That's at least what I've seen. Now, botulinum toxin, why would this come up on the list? Why would this help prevent migraines from occurring? What does botulinum toxin do? Paralyzes muscles, right? So why would paralyzing a muscle help with migraines and preventing them? Yeah, you have muscles in the head. Imagine like in the back of the neck, these muscles are chronically pulling back. That can lead to those migraines. And so there's cases where you can actually inject small amounts of Botox into those muscles and cause a relative paralysis there, and that will help to relieve that stress, and it will help to prevent the migraines from occurring there. So again, you'll find a lot of use of Botox. We use a lot of Botox over at Nemours, and you're like, man, those kids are looking great. They don't have any wrinkles. No, we don't do that. But we do things like, for instance, in the GI tract, or if we have kids who have like CP and they have spasticity issues, we can definitely inject on those muscles and relieve that's all that contraction. So a lot of use of Botox you'll see in other uses than just for aesthetics potentially. So as I mentioned, the preventative therapy, start low and go slow, because you don't want to initially cause a migraine due to things like a calcium channel blocker or a beta blocker like they may induce there. You can try it for a couple of months, see how they're responding. You can consider tapering off if you want to, or they can be on it for long periods of time. It just depends on the patient and sort of what their triggers are, how often they get their migraines, etc. Again, always consider their comorbidities when you're deciding which one to use. So like if I had a patient with asthma, then propranolol probably would not be a good option. Or if I had a patient who, for instance, might be getting pregnant, which one of those preventative therapies would you not want to use? Valproic acid, right, because of neural tube defects and things like that. So very good. What would you monitor for if you started a patient on valproic acid? LFTs, right? So if they had a history of liver dysfunction, that may not be a good option for them either. So a lot of things to consider there. So again, looking at their comorbid conditions too, like imagine what if they have like say depression, right? Well, using something like an antidepressant drug might be able to provide double duty. That's kind of nice from that standpoint. They have hypertension or angina. Well, a beta blocker might be a good option, and maybe they may be on one of those medications already anyway. Maybe it's causing their migraines, but maybe it could also be used as a prophylactic potentially. So kind of just consider all the different options here based off of their basically their comorbid conditions and see how they're going to respond to that. Anyways, you can kind of go through that and see kind of what the different options are going to be there. This one recommends beta blockers first line. However, I do see several patients who end up on topiramate quite commonly, so it just depends on the provider and what they think is going to work best for their patient. Any questions on that? If not, I would like to jump into the next section. I have about 20 minutes I want to use here.
I just have a question.
Yes.
Topiramate, do you still have to monitor for metabolic acidosis, or is it like lower doses?
You would still maybe watch for it. It's not like a severe metabolic acidosis. It's not like you're gonna like check them and their pH is like 6.9 or something. Like what's a normal pH in the blood? 7.35 to 7.45 typically, right? So 7.4 is considered pretty middle of the road there. So you may get down to like a 7.3, 7.2, something like that. Not like a severe like DKA where it'd be like 6.9, 6.8 or something like that, right? So you'd watch for it, right? And remember, it'd be a non-gap acidosis. So they probably have a hyperchloremia, even though the bicarb might be low, and the anion gap would be negative essentially, right? Not negative as in less than 0, but it'd be not abnormal, right? Okay, any other questions on that section? Okay, so let's get into behavioral medicine. This is a good sort of transition from the neuro stuff into the behavioral stuff, because again, we're dealing with neurotransmitters, we're dealing with a lot of medications that work on similar systems here. We'll start with something that I probably induced in a lot of you over the course of the last few months. It's okay. I'll bear this burden for all of you. Anyway, you'll find that depression and anxiety are frequently things that go really well hand in hand for a lot of patients. Their anxiety can exacerbate depression and vice versa. And so you'll actually find the treatment for the two may be similar in some cases here, as we'll focus on. Now, have you covered much behavioral health stuff anywhere else yet? Not till the summer, really? Okay, well, I don't teach you in the summer, so this is where you're going to be getting it. So this is it. I'll try to do a little bit in terms of background information, just so that way we can all be on the same page in terms of talking about this stuff. But if you have any questions or anything, or if I mention something that I'm taking for granted that you know, just raise your hand up. We'll go over it in more detail. Anyway, so treatment for depression, and again, do you think depression is something that's typically undertreated in patients, overtreated? Why do you think that? Yeah, people get embarrassed. They may not seek treatment because they are in the midst of depression. They may not want to get out of bed to go get help for themselves. Like, there's a lot of reasons for it. There's a lot of negative stigma attached to it. Nowadays, I'm starting to see that people are more able to talk about their mental health issues. More people are able to get the help that they need, which is a great trend. But certainly, there's still a long way to go here. In terms of pharmacotherapy, you're going to see that we've been able to treat this for a really long time, like since the 50s. And we used to use like just really toxic meds that we'll talk about in some detail here. Nowadays, though, we have much safer alternatives. And why is that important that we have safe pharmacotherapy for patients being treated for depression? Yeah, if they try to commit suicide, guess what they're going to grab? Anything available to them potentially, and that includes our antidepressants. So if I have a patient who accidentally overdoses or intentionally overdoses on a TCA, a tricyclic antidepressant, that's a heck of a lot more worrying than something like an SSRI. We'll get into those differences between there. And so this is a good trend that we're getting safer medications, right? Also consider that the non-pharmacologic therapy really needs to be a heavy emphasis for you as well. Drugs don't just work by themselves. You need to do other things as well. Get the cognitive behavioral therapy, do other things to try to mitigate stress and other things that help the patient out, right? So drugs are great, but they're not going to be the savior for every single patient out there, potentially. Also, it's important to consider what are other things that may be going on to exacerbate the patient's depression, or maybe just causes for it altogether. So do they have hypothyroidism? Do they have Parkinson's? Medications can also lead to depression itself, or can worsen depression. We talked about isotretinoin and Accutane. That had a risk for causing suicidality in patients, right? Anticonvulsants, cardiovascular meds can all sort of mimic the effects or can exacerbate depression in patients. So you do want to consider that. Even things like oral contraceptives For some patients, it actually helps improve their mood. For other patients, oral contraceptives can worsen their mood, as you will find. It just depends on how they particularly respond to it. And again, many patients who are underdiagnosed or undertreated, they may be coming to see you and as a suicide attempt potentially, right? A lot of times they may be unsuccessful, and that's when you might see them. Or if they are successful, then obviously they're just going straight to the morgue and you would not see them. But we do get a lot of patients, and when I was in my fellowship, and I still take call, the vast majority of calls that we get from hospitals are going to be patients who are either intentionally harming themselves for suicidal purposes, or they are abusing medications, have kind of gotten themselves a little bit into trouble from that standpoint. So that's a very common thing we see, especially in the ER setting. Looking at anxiety, there kind of encompasses a wide range of disorders, anywhere from like panic disorder to PTSD. We have the big VA here in Orlando, right? If you go and work at the VA, guess what you're going to see a lot of PTSD, right? So it's important to kind of consider all these other things that may be playing a role in your patient. Like I said, depression, anxiety, they are nice bedfellows. They oftentimes go hand in hand. You can manage both together. It's going to be very beneficial for your patients. So why do patients get depressed? Think serotonin, okay. Serotonin, lack of, too much. Think a lack of, okay. You can't just tell someone, just stop being depressed. Just put on a happy face. One time I got in trouble. My wife was feeling kind of blue one time, and I was like, you know what you need? You need some positive mental attitude. So PMA. You know how well that went over? Not well at all, no.
How did the couch do that?
The couch was cold and lonely, much like I was. No, it's like just like telling someone like not to be worried about something. Just stop worrying about it. You'll be fine. That doesn't help. Don't be anxious about that. It just makes you more anxious a lot of times, right? Anyway, so you said lack of serotonin, right? So why do we think that? Well, there are several different neurotransmitters we're going to be focusing on here. Mainly serotonin probably is going to be the lion's share of this. Norepinephrine will be playing a role, and then dopamine as well. We'll talk about in some minor aspects. We think that serotonin depletion has to do with depression because there actually used to be this drug called reserpine. It was an old antihypertensive, and it basically caused you to deplete all of your catecholamines like serotonin and dopamine and norepinephrine. And guess what the patients felt like when you got rid of all those neurotransmitters? Mopey and sad and not have much energy because you basically don't have any neurotransmitters to be activating all these systems here, right? So okay, well that led to depression. It must be due to lack of serotonin. And so you can give antidepressant drugs that will directly increase levels of serotonin, but patients don't necessarily start feeling better right away. And so there's a disconnect there. There's probably something much more complicated happening that we just don't know about what it is yet. And so essentially what we find is that I can give patients things that will increase serotonin right away, but it takes weeks before the antidepressants really work. Up to like maybe 6 weeks in some cases there. So that's one of the big caveats you'll take away from this, is that even though patients may experience side effects initially, right away, they will not get therapeutic effects again for several weeks, okay? Now, is compliance an issue with patients with depression? Why is that? I don't want to take it, what's the point? Very kind of nihilistic sort of view on things sometimes. Like, yeah, of course adherence is going to be an issue here, right? Not only that though, but like we actually find that there's a lot of placebo effect of these medications as well, right? So, imagine if you are taking, say you're entering into a study and they say, okay, you're either going to get placebo or you're going to get this antidepressant. You have depression, we're going to give you one of these, and you start to take, you don't know what it is. You're thinking, okay, I'm taking something for my depression, okay, this is feeling okay. All of a sudden they start to feel better, right? Placebo effect is a real thing. Mind over matter is an important factor here. And you'll find efficacy in these placebos that you're like, okay, well, compared to the drug itself, the drugs don't actually seem that much more effective. So there's a lot of other complicating components to it that you're going to find here. So that's why it's really difficult to say, well, this is the one antidepressant you always start with, because patients respond so differently to them. And the adverse effects are really going to be what dictates which one you're going to use for them. Obviously, our goals here are to try to reduce their symptoms of depression, try to get them back to a normal level of functioning so they can get up and clean their house and go to their job and interact with their loved ones and all the stuff they would do at baseline, and hopefully prevent any kind of further relapses, right? That's ideal, what we'd like to do. Typically, you'll find that treatment will kind of go into 3 phases here. The acute phase, meaning we want to get remission of acute symptoms. Maybe this is when you see them for that suicide attempt potentially. There'll be that continuation phase afterward where we try to eliminate any residual symptoms and try to prevent recurrence. And then they get into a sort of a maintenance phase where hopefully they'll just be kind of maintaining, staying at their baseline there. Some patients require lifelong therapy. Sometimes if it's more situational, they may only require a few months. It just depends on, was there a death in the family recently? Was there just some major stressor? Or is it just, that's them, that's their neurochemistry, they just need to be on this forever. That's okay too. But education and adherence are really, really critical here, which is why it's good to incorporate other things like CBT and other means of helping with their depression. Like, you only see synergy here when by combining them together. Even we have other things like, electroconvulsive therapy. Like, what is that? Isn't that shocking we use that still? Okay. Some of you are a little sleepy after that, right? Shocking that we use that? Yeah. This is electroconvulsive therapy, yes, but it can be effective in some cases there. I'll blame it on the test. You guys are in a fugue state afterwards. I mean, you're in a post-ictal state after that test. But even there's other things like this repetitive transcranial magnetic stimulation. This is something I had a friend that was working at a wellness center where they did a lot of like complementary medicine techniques and things like that. And they would basically have this device where it basically like would beam these magnetic waves through the brain, and they actually found some decent effects. There's actually some literature to say that it does help out with depression. So a lot of different options there. And again, frequently what the patient feels like is helping them will help them in a lot of cases, right? That mind over matter is really, really important aspect there. So getting into the drugs though, we're gonna say that, around 30 to 40% of patients can respond to placebo. I mean, that's a really effective sugar pill, right? That's extremely effective, I would say. 30 to 40% of patients respond just to no drug whatsoever, just by thinking they're taking something. That's pretty good. Typically, how we're going to be making our choice for what we decide is going to be based off things like history of response. So maybe they've been on one of these before that did or did not work well for them. If they have any concurrent illnesses that may be exacerbated or helped by one of these medications here, how they're presenting in terms of their symptomatology, and then also things like drug-drug interactions, the adverse effect profile, patient preference, all these things you'll take into consideration. And it'd be nice if I could say, always start with this one, but that's not always going to be the case. It won't really work. And I'll have students will come back, and students always get kind of frustrated when they have this whole plethora of options, and then they're like, which one do I do? And you're just like, I don't know, just pick one. But then they'll come off of like their behavioral health rotation, they'll come back and they'll be like, yeah, it's exactly like what you said. They just say, okay, try this one this time, that didn't work, okay, try this one instead, right? There's not a whole lot of science to it necessarily. It's more art than that. How we classify our antidepressants are typically either based off their chemical structure. So when it's like a tricyclic antidepressant, that's based off the chemical structure of the drug, or it's based off the mechanism. So when I say monoamine oxidase inhibitor, that's exactly what it does. Or if a selective serotonin reuptake inhibitor, that's just what the drug does. So you'll kind of be able to classify them based off of that. And it also will help us determine what kind of side effects we'd expect to see based off their mechanism of action. As I mentioned, 2 to 6 weeks before you really see full effects out of these medications here, even though side effects can occur right away, okay? So you do want to be aware of that. Make sure you're educating them and say, hey, you may not feel better right away, but in fact, you may feel a little worse, but stick with it and you will see some effect, hopefully. A lot of patients may fail pharmacotherapy with antidepressants, either maybe due to resistance from a pharmacogenetic standpoint, maybe just due to the fact they were not taking an adequate dose, or maybe they were not trying it for long enough, or it could be non-compliance, right? So say your patient comes back and sees you and you're asking, okay, how's the drug working for you? They're like, I don't feel any better. And you say, well, are you taking it like you're supposed to? What did I say? Mm-hmm. Okay, well, I have no idea. Like, are you actually taking it? Are you not? Is compliance an issue? That could always be something to consider, right? So, as I mentioned, just placebo itself can lead to pretty strong effects here. Natural, patients will just naturally have remission of symptoms, sometimes in 6 to 12 months or so. However, a lot of them will have relapses. That's one of the things we can try to prevent by using chronic therapy there. As I mentioned, in terms of efficacy, there's not really one that's going to work better than the other. SSRIs work as well as TCAs, work as well as monoamine oxidase inhibitors. The big differences though are their side effects at both therapeutic doses and also in overdose, right? So I ever talked about sphincter tone before? I talk about how worried I am about patients. So say if I get a call at the poison center and they say, oh, they took too much ibuprofen. A sphincter tone doesn't get really too tight around that, right? So I'm just like, okay, it's like a 2 or 3. If I hear an aspirin overdose is pretty significant, that's like an 8 or a 9. That's pretty bad. If I hear something like a TCA overdose, that's like an 11. That's like patient is very at risk for dying from the overdose from these medications, right? Which is not great because depressed patients are at higher risk for taking too much of that stuff. Versus something like our newer drugs, like our serotonin reuptake inhibitors, they're relatively safe. You can take handfuls of that stuff and not really experience significant toxicity. So that's really been the big difference here, is that the newer drugs, we go with those first because they tend to have a wider therapeutic index. They're much safer in overdose and at therapeutic doses than you would see with some of the older drugs, right? So looking at the different classes, and again, I probably won't have time to get super in-depth on these, but at least kind of give you the major categories. We'll start out with our early ones. These are going to be the monoamine oxidase inhibitors. These are basically preventing breakdown of serotonin and norepinephrine. So you have higher levels in the synapse. We think that that helps lead to some downstream changes in the neurons that lead to resolution of symptoms. Next, we have our TCAs. Instead of working on the breakdown of these neurotransmitters, they actually block the reuptake, right? So our neurons like to be economical about their neurotransmitters. They like to recycle if possible. So once they send them out through the vesicles, they'll pick them back up through these transporters. By blocking those, what happens to the synaptic level of the neurotransmitter? They'll increase, right? Because more of it is being blocked out and staying outside in the cold, so to speak, right? So staying there, they can interact with those receptors. They work on both serotonin and norepinephrine. To get more specific, then you have your SSRIs, which are going to be working just on reuptake of serotonin. This is probably going to be your gold standard in terms of initial therapy. Most patients will probably start with an SSRI because, again, it's going to have very clean in terms of mechanism and the safety profile. And then the newer set of drugs are going to be the SNRIs, and these will also block reuptake of serotonin and norepinephrine. And based off this slide, it looks like it works pretty similar to the TCAs. You're going to find TCAs have a lot of other side effects you're going to run into, other receptors they'll interact with, that makes it much more of a dangerous class. So you can also say, kind of as you're going down, like safety profile is getting better as well as you get to a little bit more of a clean mechanism. These drugs here, the SNRIs, only work on serotonin and norepinephrine. They don't really do much else. So looking at this slide here, we can kind of see how the different mechanisms will be working. So say, for instance, here we have a serotonergic neuron, and here we have a noradrenergic neuron, putting out norepinephrine. Typically, you have these little vesicles just kind of hanging out there, waiting to be released. Some signal will come along saying, hey, let's go ahead and release this out into the synapse here where they can interact with their postsynaptic receptors, right? Looking at something like a monoamine oxidase inhibitor, basically by blocking these enzymes, you block the breakdown of the neurotransmitters, such you have higher levels, more can be released into the synapse, and more to interact with those postsynaptic receptors, right? Pretty straightforward, just like we looked at, say, dopamine or monoamine oxidase B inhibitors with, say, for instance, Parkinson's, right? You block the breakdown of dopamine, you have more dopamine to interact with those receptors, such that you get movement, right? Pretty straightforward. TCAs and SNRIs are going to work on both these norepinephrine transporters and these serotonin transporters to block the reuptake, such that once it's released, more of it stays out here in the synapse to interact with the postsynaptic receptors. Okay, the SSRIs only work on the serotonin reuptake transporter. Okay, so that's going to be the big difference between these classes here. We'll talk about TCAs in more detail next time, probably when we get into some of the other sort of ancillary effects there. Okay. So you can refer back to that if you kind of need a pictorial example of how these drugs are working. Okay. In general, though, the main point is we're enhancing norepinephrine and serotonin. Even though we don't know why it helps with depression, we know that it does, right? At least we have evidence to show that that is the case here. And again, there could be a number of different things, a number of different theories on why that occurs. All of these I'm not going to quiz you on specifically, but just know at least the mechanisms of how they're enhancing serotonin and norepinephrine effects. And again, we'll talk about how that works in terms of side effects for sure, because we definitely know how that happens. So I think I'm going to cut it there before I get into all the depth of these drugs. Any questions before I let you go? Look on the board and see if there's anything. Oh, I got one. Okay, how can you justify putting patients at risk for adverse effects with antidepressant medications given a natural remission of 6 to 12 months and the efficacy of placebo? Interesting. How can we justify that? That's a very confrontational sort of question. So the question is like, you know, I don't know, when I kind of think about it, it's like, would I be counseling a patient and be like, okay, we're not going to give you anything, but you're going to be depressed in the next 6 to 12 months, and you may have remission of symptoms. That might be a tough pill to swallow, no pun intended, right? I don't know that would be necessarily the best way to counsel them, versus if I give them a medication that has some efficacy. So it's not to say they have no efficacy, it's just to say that, again, there is a powerful mind over matter component to that in addition to the effects of the drugs itself. And again, you'll find that most patients do tolerate things like SSRIs pretty well. You're going to find they're fairly effective at what they do, and they're tolerable. And so you can say, okay, well, but within 6 weeks, maybe we can start to help improve your symptoms, right? Because again, what am I ultimately trying to prevent them from doing? I don't want them to be a call at the poison center potentially, right? I don't want them to become a statistic. Before that, though, you want them to be able to go to work and be able to interact with their loved ones and do all the things they want to do, right? So there's that component to it. Also, if you were to tell a patient, hey, this is a sugar pill, but go ahead and take it and you'll feel better, do you think they're actually going to feel better? No, the placebo aspect of it only is contingent on the fact that they think they're taking something, And ethically, I don't know that you can necessarily write in your chart, I'm going to give this patient a sugar pill because it might work and I don't want to give them side effects. Maybe give them diabetes. I don't know. Probably not.
If it has proven efficacy in this case, like, you would say that.
I don't know. I mean, go back to the, but if I have a 30 to 40% chance it might work versus medications that I know have higher percentage chance of working, I'd probably want to go with that, right? 30 to 40 is not necessarily good odds. I don't know if I bet my life savings on 30 to 40% chance of something happening, right? Versus maybe higher than that with the actual drug. So it's a good question, though. It's a good kind of thought experiment to think through for sure. But any other questions before I let you go? All right, I'm going to take a look at the tests, and I'll put an announcement if there's any give backs or anything like that. But at least there is one missed key, so be aware of that, okay?